It would be like me telling a nurse, well, I know how to use a computer. I know how to use a mouse. I have access to the electronic health record. Like I can circulate. Can you imagine me telling a nurse oh, I got your job. I'm fine. Well, I'll learn it on the job training. Well, there are massive legal implications to me screwing that up. And that would never be okay.
Rising above the buzz of ultrasonic cleaners and the clanking of stainless steel are the ideas and voices that are changing an industry. You're listening to the Beyond Clean podcast, the central nexus for the people, processes, and products that are improving our sterile processing world. Each week, we speak with frontline technicians, CEOs, engineers, and entrepreneurs with a common goal: to help you fight dirty, every instrument, every time. Whether you're tuning in for education or inspiration, we're glad you did. Now turn on those washers and turn up the volume. It's time to go beyond clean.
All right, Clean Freaks, welcome back to the Beyond Clean podcast. It's good to be with you again on Monday morning. My name's Bobby Parker, and joining me in studio today is Weston Hank Balch. What's going on?
Hey guys, good to be here, Bob. This is going to be a fun one.
That's right. We're talking about certified surgical technologists today. I feel compelled to say technician when I come across that CST title. Must be that SPD background, but they're very proud of that technologist title. So make sure you keep that one straight when you're talking in your OR. Now, Hank, we're continuing through Planet Surgery season 27. And I realized after a couple episodes, I don't think we've let them in on the secret of what's this whole Planet Surgery thing about. So let's let them in on the secret. What's the deal with Planet Surgery?
Yeah, it can be a different world in the OR. We spend a lot of our time in our departments in SPD. Every now and then pop in our head to deliver an instrument, maybe ask a question in the OR. But if you're not in orientation and viewing a surgery, you're usually not in the OR when our instruments are being used. So yeah, the vision for this is to bring us out of our world into their world and begin that conversation, share that insight, and hopefully get some challenges along the way for us to maybe think differently.
Well, we've got the right person to bring us into that world, Chris. As many of you have probably heard her before, is a great educator, and we haven't had her on the Beyond Clean show much, so looking forward to talking to her about surgical technology. So hang with us. We'll be right back.
From the studios of Healthcare HQ, you're listening to Beyond Clean, the global voice of sterile processing.
All right, Clean Freaks, we are in studio now with Chris Blevins, the Senior Department Chair at the Surgical Technology Programs at South College, and the founder of The Scrub Life and co-host of the First Case podcast over on our First Case channel. Chris, you are all over social media these days, bringing so much value, conversation, insight to the surgical tech conversation. We're really delighted to pull you over into the Beyond Clean channel today to pick your brain about these things.
Hi, Hank. It's so good to be on this side of the microphone. So thank you for having me. I'm excited.
So even though I know you pretty well, we've gotten to know you the last couple of years more and more through the show and through other collaborations that we've done. This might be the first time that many of our sterile processing audience has been introduced to you. So maybe give us a little intro to who you are, where you got to, what you're doing today, and I guess what you do with your day.
It's a busy one, that's for sure.
I'm sure, yeah.
No, I'm excited. So yeah, I run 8 soon to be 9 surgical technology programs for a college, South College across the country. My home base is Knoxville, Tennessee, although I rarely get to see it, unfortunately. But in clinical practice, I am a certified surgical technologist. I was a trauma scrub. I did liver transplants, some cardiovascular, labor and delivery, dabbled in eyes. unfortunately, but it made me a better educator. And then, I created a podcast called The Scrub Life. And then I think that's how I met you all. And then thankfully I co-host what I jokingly refer to as like my weekly therapy session with Melanie Perry. And we get to talk to some amazing people. And I think voluntarily, I served on a lot of committees for our National Association of Surgical Technologists, and I've contributed to our textbook, and I help out our accreditor, and I'm just super passionate about surgery and surgical technology and sterile processing and just the whole field. So I can't really get away from it willingly. But so busy girl, but happy life. And so I'm excited to talk to you about everything today. So, and thanks to the listeners as well.
Let me ask you before we jump in to the meat of this episode, and I kind of explained it to you before we started recording. This is the Planet Surgery season, so we're looking at what's happening in the operating room related to instrumentations through different perspectives, and obviously we're pulling you in for the surgical tech perspective. But before we get there, your role as a program director's department chair is one of those roles I think a lot of people in the industry, a lot of clinicians, potentially early on in their career or even toward the end of their career in a hospital setting, they look at those kind of roles and be like, that'd be a lot of fun to teach. And it'd be a lot of fun to go in these programs, to train up the next generation. But how did you get from the clinical side to the teaching side? What was that journey like? How would you encourage people to prepare if that's the direction that they want to go with their careers?
Man, that's such a good question. It's kind of happenstance, to be honest. We teach already just in the operating room. I think you teach the next generation. Those of us who, especially when you specialize in those fields like CV and neuro and transplants, you're constantly training the next person. A lot of the times because, good grief, we take a lot of call. And so, you want to train somebody else to be able to do what you do so that you can get somebody on the call team, right? And then we have students in the OR all the time too. And by God, be a preceptor, teach those students, don't eat them. Please. And that's it. Don't get me on that soapbox either. Right.
Yeah.
But, so we do a lot of teaching in there anyway. And so I was at a point in my life where I wanted to do more. And so actually I was going to go to PA school. I had to take molecular biology. Lord help anybody who has to go through that. And so I was finishing up that prereq and getting ready to go into the next step. And actually it was my old clinical coordinator who has now become the program director of the school that I graduated from for surgical technology. And I would volunteer and be her surgeon for her practicals. And she contacted me and she said, Chris, the program director from a school in our area had passed away suddenly. That coordinator was going to take over and they needed someone to join the team. And she was like, I need you to go and apply for this job. And I said, Miss Allen, I'm going to go to PA school. Like, no, ma'am. And being this student, because once you're ours, you never go away. Like, you're always our babies. And so just like that, she said, Chris, go apply for this position. And I said, yes, ma'am. and so I applied for it, even though I was like, I'm going to go to PA school. Like, I don't have time for this, but I applied anyway, because I'm not going to tell my teacher no, even as a grown adult. And so long story short, like, I ended up taking the job and I thought, okay, you know what? I'm going to pause. Like, I'm going to take this job. Maybe it's the right step and I can always just go back if I want to. And next thing you know, like, I just fell in love. It's this light bulb moment because, surgery and even the world of sterile processing, it's a completely different language. I mean, nobody speaks the things that we speak. And you watch these kids and these adults that have these light bulb moments, and they learn these techniques and you just watch their eyes light up and you watch them go from these like bumbling goofballs. And then it becomes this smooth flowing, dance almost. And you just see them gain confidence and you just watch them rock it. And there's so much to gain from that. And I don't know, I fell in love with it. And so, yeah, so I don't know, I minded my teacher, which is a good lesson out there for all you students, by the way.
Yeah.
Like, just mind your daggum teacher, right? But that's how I fell. That's how I fell into it. So if you ever think like, why would I ever want to go into education? You already are. Like, if you're good at your job in the operating room, you're teaching every day and you're already a team player. But the key in our field is go get the degree. Our hospital systems, as you know, Hank, like they don't reward you for getting that academic degree. They reward you for getting certifications and for specialization. So a lot of us that went and got that higher degree, most of it is you got it because it was just something in you, like either or your parents pushed you. And for me, no one else in my family had the higher degree. And it was just something I needed. And I was pre-med, and that's what I wanted the degree. But that degree opened the door in order for me to get into the world of academia. So if you ever think maybe I might one day want to get out of clinical practice, go check that box. You have to at least get a bachelor's degree. It's not hard to do, especially with online learning nowadays. But that's how you have to be able to at least make that a possibility. Just go get the degree. It's totally worth it in the end.
That's a really cool story, how a mentor or a teacher kind of guided your path and you fell in love with it. I think that a lot of us would identify with that. Chris, we're really thankful to have you on this show representing certified surgical techs as we're talking about kind of this topic of who's in the OR. You know, we called the season planet surgery, and that's exactly what it feels like for a new sterile processing technician. We're on like a foreign planet in here. Like, who are all these people in the room? So at the very base level, as we kind of start the meat of the interview, could you just give us a summary of who are those individuals that are in the room that we're encountering in this fort?
Yeah. I tell people all the time we're the ninjas in the operating room, right? I mean, we look like it. We have a mask on, we look like this. Nobody can see us. Most people have no idea what a surgical technologist is because our clientele, right? Our patient population, well, they're drugged when they meet us. We typically don't go, we don't go into pre-op and meet the family. We don't have that interaction with them that our circulating nurses do. So because we're in the operating room, we work for the hospital system. Typically, we're assigned an operating room or a certain surgical service. And our job is to prepare preoperatively for the procedures that are happening that day. Our job is to participate as a part of the sterile team that is taking care of that patient. And then once we are through with that procedure, we, help bandage the patient. We help transport that patient to their stretcher. But once that patient goes to PACU or recovery, we don't go with them because we are then turning over the room and getting ready for that surgeon's next procedure. So you are drugged when you meet me, and you are unconscious when you leave me, and all you see are my eyes. So no one outside of the Grey's Anatomy world, God help you, knows who we even are. And so we're an entire field in the allied health industry that I think can be a mystery to most people, but it's a fascinating profession that's very misunderstood. We have to be the experts on sterile technique in the operating room and we actually are. We get the most training, 18 months to 24 months on sterile technique. And everything that we do has to be extremely precise because if we have a break or contamination, what we do can injure or kill that patient. So, there has to be a lot of integrity in what you do. Most of the things that we do are done without a witness because the circulating nurse is off doing their job. Anesthesia is off doing theirs. The surgeon isn't typically with us until the patient is. So a lot of the things that we are doing in preparation within that sterile boundary is done on our own. So you have to have a lot of integrity. If you do, you're human, right? So if you do contaminate something, if you see something that is wrong, like we have to fix it immediately. You have to be able to communicate those things, recognize them, and fix it, because that patient's life is in your hands and they don't even know that it is. So, it's an honor to be a surge tech. It's an honor to teach the next generation of surge techs. So, I
awesome.
can go off on it.
Right. That illustration of ninjas of the OR, I think, is going to stick with me. Silent as a demon's whisper.
Yes, lethal.
So, I don't know a whole lot about ninjas. Like, are there different tiers of ninjas, master ninja and whatnot? But why don't you tell us a little bit about the different types of education or certification that surge techs can go, and maybe different paths? Like, is there a difference between a first assist and a surgical tech, and kind of what those paths look like?
Absolutely. So we are an associate degree level profession. And then there are different certifications. So it's a national certification as opposed to like a regional licensing for nurses. And there are two recognized certification, kind of the top tier certification is called the CST. So it's a NBS TSA. Oh, here comes alphabet soup, right? But it's the National Board of Surgical Technology and Surgical Assisting. It's a very hard exam, but once you pass that exam, you are allowed to hold the credential of CST, or Certified Surgical Technologist. And they're the only ones who can be called a CST. There is another recognized credential called the TS-C that is maintained by the NCCT. It is recognized. It's considered a lower standard. You cannot be called a CST. You are called a surgical technician certified. I think that gets a little misconstrued.
That's not confusing at all.
Right? Yeah, no kidding. Just go get the NBS TSA certification. Like, just go for the top, tier of the tier, in my opinion. You can also go to surgical first assisting school. It's a different level. So whereas the surgical technologist role is actually incorporates setting up the procedure, that includes the instruments and the supplies, preparing the back table, the Mayo stand, everything that the surgeon needs in order to perform the operation on the patient. And then once we are draped out, I guess for a visual for the podcasting world, so it's to compare it to fixing a car, right? So you have to have everything you need before you pop the hood. So then once the hood's popped, right, we are then handing the surgeon and passing all of the instrumentation to the surgeon. But then sometimes we also assist and retract anatomy. We hold other instrumentation. We hold the camera during minimally invasive surgery. So we become the eyes of the surgeon in those instances. But also sometimes in more complicated procedures, the surgeon needs another set of hands on the anatomy to help perform steps of the procedure. And that role is typically done by a surgical first assist or a very experienced surgical technologist. So first assisting is another kind of level that you can go to. And there are a lot of schools for that are highly recognized. I won't give them props, even though I have a favorite. They know who they are. But yeah, and a lot of CSTs then go on, many of us go to PA school. Many of us go to medical school. Many of us become educators, and many of us stay as a CST forever. Some go to nursing. It's a great pathway that can open your eyes and lead to other roles within surgery and healthcare in general.
No, it's really helpful. And as I'm thinking about kind of those different paths and the certifications, coming from the sterile processing background, there are a couple of different tech certifications that can be had. But in most states, they're not required in order to begin the job. Some of them, they require it a little while after you've started the job. Is there any similar environment still hanging around? I know there used to be, where nurses could be trained to be OR nurses, or even just, like a surgical assistant, CNA could be trained to be a surgical tech, or somebody could be trained to be a first assist without going through those various degree programs, or is that shifted?
Unfortunately. Okay. Yeah. So there are some states that do not have legislation that requires certification, and that's dangerous because, like I said, 18 to 24 months of education on sterile technique, on asepsis. You cannot afford to be ignorant on the rules of sterility. And I'm sure this is a soapbox that you all get on in sterile processing all the time. If you don't understand the IFU and the proper, disinfection and sterilization of that particular instrument, then you don't know whether it's sterilized. And that would be the same exact thing for our role, is that if you do not thoroughly understand the sterile technique for properly gowning and gloving, or the sterile technique or the rules of engagement for what you are doing in that role, then you cannot critically think through when you have broken those rules. And it is impossible, nor is it correct, to have a patient be a guinea pig for someone who is on the job training to learn those rules through trial and error. It's not fair to that patient. It's not fair to that patient's family. And it's not fair to the person who's been thrown into that position overnight. But the problem is that we have a national shortage of surgical technologists because, like I said, we're ninjas. There are very few people. We've done a horrible job as a profession of marketing that we're out there. I think the pandemic, unfortunately, sort of helped in healthcare in general, right? That there are a lot of these providers out there that are taking care of patients, but we have not done a good job telling the public that we are an option for healthcare, and we need to advocate better. But because there's this national shortage, the hospital systems are trying to get creative to put warm bodies in these roles. But unfortunately, sometimes that creativity is causing more of a problem. And that's what's happening. But it is not the right thing to do. You need to be properly trained. It would be like me telling a nurse, well, I know how to use a computer. I know how to use a mouse. I have access to the electronic health record. Like I can circulate. Can you imagine me telling a nurse oh, I got your job. I'm fine. Well, I'll learn it on the job training. Well, there are massive legal implications to me screwing that up. And that would never be okay. So, to turn the table, it's not okay for someone to try. And just because they've seen it, I stayed at a Holiday Inn Express overnight does not mean that you can then learn our job and the rules of asepsis as well. So yes, unfortunately, we do have that in a few states, but we are working hard to correct it.
So let's talk instrumentation here, Chris. You gave us great context around the credentials, the background, the training of these surgical techs in the room. You talked a little bit about that integrity piece in the setup stage. I think that was just a really important point that I have not considered in the context of that category of integrity and how important that is in this role. As the procedure is getting set up through the span of the procedure, from the cut to close to wheels out, what kind of stressors are most common for a surgical tech to encounter? And would tie those in to specific instruments or specific instrument related stressors, again, because we're going to have SPD listen to this, and we get the phone calls. And sometimes we can sense the level of stress based on the tenor of the conversation on the other line. But we don't really get a firsthand seat at how do you discover the stress? What's the response of the room? How do you manage it? So kind of talk us through that.
I think stress comes at different levels depending on where we are in the surgery. And things roll downhill. When we're setting up in the operating room, time is money, and time is always of the essence. And I think that's probably one of the biggest stressors prior to the patient being on the table. It's just time. And for a surgical technologist during setup, when you all have the instruments in sterile processing, in order for you to do your job to decontaminate, clean, and then sterilize, all of these instruments must be taken apart completely. And so for us, once we get that wrapped or casket, and we have then, as a sterile person, can undo that wrap, our job is to put it back together again so that we can use it sterilely on the patient. And there are thousands of instruments. And so to be able to understand and put all of those thousands of instruments back together again in working manner quickly so that the surgeon can use it is hard. Thankfully, there are instruments that have been developed that are allowing us to do some really amazing surgeries and take care of patients we couldn't take care of even 10 years ago. But good grief, some of them are really complicated. And so I think that's a big one is how do we put together, I immediately am thinking of like a resectoscope, for example, trying to put that thing together and make all of those parts move at the same time can be a pain in the butt. Haha, sorry. Bad joke. And, and then intraoperatively, if something is not working or if what we have on the back table and we run into a problem with the pathology that we're experiencing within the anatomy of the patient and what we have open isn't working, the time's of the essence, right? And stress within the OR, especially coming from the surgeon, is very, very high. And you have to remain calm as a part of that team. And you also have to you can't take anything personally. That surgeon is stressed out and they're probably not using their inside voice not because they're mad at you, but because they're concerned for that patient and they need to fix the problem. And so you have to be able, and they're not looking at the anesthesiologist. They're looking at us. And we are then looking at our teammate, the circulator, who is then calling you because we need help. We need to find the right tool in order to fix the problem for our patient. So trying to critically think and get creative and also know what is in our inventory and what options we have to be able to provide for that surgeon and do it on the fly is also something that can be difficult to do from an instrument point of view. And then lastly, I think postoperatively or in transition, it's making sure that turnover happens quickly and that we've done everything we can so that we already prepared for the next case. And I think one of the things, if there's any advice that I could give to my fellow surg techs that are out there listening that could help sterile processing is do not open every single pan looking for one instrument. We're horrible about doing that. And then also making sure that in real time, we are taking care of the instruments while we are in the surgery to do what we can to help our sterile processing department, clean the instruments, flush out lumens, do all of those things that you can do to get any, bioburden and all of that out and tissue out so that you are helping your sterile processing department be able to decontaminate those instruments in an effective and efficient manner. So all of that and all three of those steps take communication between the team and also respect. And fostering that culture, I think, starts from my job as an educator with the students and the leadership within our clinical facilities.
Because we're going to pick back up on that cultural piece here in a second, but I want to ask you a couple of follow-ups just on that flow that you described. So you mentioned a part about aseptically opening these packages in the OR. And I know as a sterile processing tech, I was kind of shown what to do when I'm wrapping packages or whatnot, or even the direction that you're putting items inside of a pill pack, for instance, in a way that matters. But can you speak to the stress that happens if you go to open a wrap, for instance, and it has been wrapped in a way that is very difficult for the surgical tech to open without contaminating themselves or the setup?
It is so hard because there's those of us who have some OCD tendencies, which I will raise my hand.
That's good, right?
Yeah, absolutely. So our field is actually a really good one for that because there's a right way and a wrong way to do everything. We also have very, very strict rules on sterile boundaries. So for any packaged item, there is a 1-inch border, right? That is considered unsterile around the outside of it. So anything that you open So a wrapper, a peel packed item, we consider the 1 inch around the boundaries, right, to be unsterile no matter what. So if anything goes within that boundary, it's now considered contaminated. So in surgery, there is no gray area. And we have a saying, right? When in doubt, throw it out. Well, if something is packaged in a way that makes it, or wrapped in a way that makes it very difficult to open, it is easy for it to fall within that unsterile boundary. And if it does that, if there is a moment where we think that it may or may not have contaminated, we must always act in the best interest of that patient and not use it. And when it comes to instrumentation, what if we only had a very few of those items? And now, because of a mistaken opening, we can't use it. And either that surgery is delayed, or, you can think of many things that can go wrong. And it's frustrating for us, and especially if you are sterile and you have a non-sterile teammate that is assisting you in doing this. We have to be very careful. I always use that Ghostbusters, don't cross the streams, Ray. You have to be very careful, because we can only interact within certain manner. Otherwise, I'm contaminated, that person's contaminated. And if my patient's bleeding on the table and I get contaminated, now I can't help my surgeon. And my surgeon may not have 2 hands to be able to help themselves. And that puts my patient at risk. So there's always a domino effect of not doing the right thing that other department may not be aware of.
So let me ask one more follow-up question here. Dirty instruments obviously can be, depending on the facility, like a systemic problem that just goes on for years and years and years. Everybody in the OR knows we get dirty instruments way too often. Everyone in SVD knows we're challenged around dirty instruments. But, the role of a surgical tech in the OR during setup or even during the procedure, what's expected of that surgical tech in relation to instruments? Because it's not like you have a borescope at your disposal or that you've got a brush to be running through things. Like, what exactly can you do to identify the cleanliness of an instrument? Or is that even your responsibility? Like, are you assuming it's sterile?
Nope.
And yeah, I don't know. Like, talk me through. But you get what I'm trying to get at, though, right?
Yeah, no, I absolutely do. So in fact, Melanie and I, in the upcoming season of our podcast, we actually did an episode on the why, right? It's called The Why. Our season's called The Why. But we did an episode on my method for teaching. It's called SIDS, Seal, Indicator, Date, Strike Through. And then you'll have to listen to the episode if you want to understand why.
Good plug.
Yes. Yeah. Right. But in that, we teach the things. We always had things that we check in order to make sure that something is sterile. And, of course, you can't validate sterility unless you have a negative biologic, right? But there are ways to check that it went through the process. But we are constantly checking from the moment that we pick up something that has, is indicated as sterile. We're checking the wrappers. We're looking for breaks. We're looking for rips. We're looking for strike through. Did something get moist? We're looking for everything. But once an instrument pan has been open, we're looking at scopes. We're looking through the lens to make sure there isn't anything that cracked. We're looking at our instruments. We're opening and closing things to make sure that they latch correctly. That's a part of our job, is to make sure everything is in working order. And then throughout the surgery, yes, we're supposed to clean it off. We are supposed to be a conduit between the instrument and the surgeon. The surgeon should never have to look up from the operative field in order to get an instrument. So even in the way that we hand the instrument to the surgeon, there is a particular way to do that so that the surgeon is handed the instrument in exactly the manner in which they will use it. So if you think about handing someone you know how to use a fork and a knife, right? And you hold that in a certain way in order to be able to eat your food. Well, I and all surgical technology instructors train our students to be able to pass that instrument in a way to where the surgeon just opens their hand. We put it in their hand perfectly in the exact same position that all they have to do is go immediately at the anatomy to use it in the same position that we handed it to them. And that you have to know A, the anatomy, and B, what in the heck is that even used for? But in order for them to use it, they can't use it if it already has fat on it or bone pieces in the rongeur, for example. So we are constantly cleaning the instrumentation anyway so that the surgeon can use it. So why not continue that process throughout the surgery and at the end of it as well? Same thing for lumens. Suction, for example, a Fraser tip suction, you can't suck anything into it if it has tissue in it. So we're flushing it with syringes. Continue those processes even at the end of the case so that nothing remains in there for sterile processing.
You're campaigning for another episode to be back, I think. We've said that.
We're loving it. We're like, keep it going, Chris.
That's
keep
right.
It going.
Repeat offender, huh?
It's really challenging from the sterile processing side of things, particularly if you've got a sterile processing leader who doesn't come from that OR background, to have those kinds of conversations around point of use cleaning if that's not happening in the facility. Because if you look at the CST standards, the AORN standards, that point of use treatment is not just, put a product on the instruments after the procedure is over. There's a lot that goes into it throughout that procedure. It's just really difficult to be able to speak into that with any kind of knowledge. And so, Hank, I think it would be fun to have kind of a deep dive on like what that workflow looks like and how do you respond to the situation when they say we virtually, literally, absolutely do not have time to do that in our cases. You don't understand how fast my doctors work.
I'll call them out on
that,
it.
Well, I mean, that's kind of the silver bullet to the sterile processing manager who has no experience in doing those kinds of things. So that would be a really interesting conversation to have. Chris, this has been a really enlightening episode. I want to say thanks for what you do in promoting certified surgical technologists, but also just educating that next generation. And thanks for educating a couple of guys who don't know a whole lot about surgery. So we appreciate you. Thanks for coming on the show.
It has absolutely been my pleasure. And I'll be back anytime. So thank you for having me.
Absolutely. And hey, we mentioned the other podcasts where folks can connect with you, but if they wanted to ask you a question directly or connect with you personally, what would be the best way for them to do that?
Sure, absolutely. I'm on LinkedIn. Please feel free to link me at my social media, and I can always be reached at cblevins, BLEVINS at south.edu. I love to help out people, especially fellow educators. It takes a village. So please, I'm here to help.
And that was Chris Blevins, Senior Department Chair of Surgical Technology Programs at South College, the founder of the Scrub Life podcast and co-host over at Our First Case brand alongside Melanie Perry. Bobby, had high hopes for this episode, and somehow, some way, we exceeded those hopes. I learned a lot. I had some aha moments myself with that integrity piece. I think I've already called out, that piece was really, really important to me. That I never considered how often these surgical techs are by themselves with nobody else around. If you see a problem, it's going to delay the case potentially. It's going to get people cranky, and yet the right thing to do, and you've got to have the courage to do it. I mean, that's huge.
Yeah, for sure. And thinking about the conversation, I don't know how much people know about how we do our podcast. There's always some amount of research, some amount of outline that we put together in kind of hopes of directing a conversation. And sometimes it gets so interesting that we go down some rabbit trails. And there were some places that I really wanted to go with this conversation with respect to talking about that relationship between the OR and sterile processing that we've talked to Chris before about. And man, I'd really like to get her back on the show, because that conversation around respect for not only caring for the instruments, but building that relationship with sterile processing is really important. And I know she's doing some great work on that.
Yeah, I know. I've worked with a number of sterile processing professionals that have been surgical techs in the past, or even at the same time. And their perspective was always different from mine. And I never understood exactly the nuances or their different ideas about various things. But even in this interview, I started seeing a little bit more how valuable both of those perspectives combined could be. Somebody who has seen everything that Chris was describing in the OR at the hand of the surgeon and all the responsibilities around that, and then also knows the sterile processing side. That seems like a really, really valuable skill set to meld into too. And yeah, obviously the certification conversation was really interesting, but we've got to come back to her again because we prepped that cultural conversation. It's like what you talked about, Bobby, and we didn't even have time to get to it. So there's going to have to be a round 2 with Chris. Hold your horses. We'll try to work it in the remainder of the seasons here in 2025. But until then, we've still got some great episodes left in this Planet Surgery season 27. I want to thank you all for tuning in. We'd love to hear your thoughts on this episode or other episodes in this season or other people and topics that we haven't covered yet at Beyond Clean. So hit us up at info@beyondclean.net. And until we talk to you again next week, keep fighting dirty.
Thank you for listening to this week's episode of Beyond Clean. As a reminder, you can help support us by subscribing to Beyond Clean on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for Beyond Clean in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@beyondclean.net. We look forward to hearing from you.